This is a very broad subject, so I'm going to limit it to what you need to know as an internist. Okay. You know that the main complications of diabetes is macrovascular disease. About 70% of diabetic patients will die from cardiac disease, and about 16% will die as a consequence of stroke. So about 85% of the deaths from diabetes is cardiovascular in etiology. And diabetic patients will have 2 to 4 times higher incidence of cardiac disease compared to non-diabetic. And stroke is also 2 to 4 times higher in diabetic subjects. The retinopathy is the main cause of blindness in adults, and it's even in these days when we think that there's a lot of advances in treatment of diabetes, still about 30% of people with diabetes over 40 years old have retinopathy. About 5% will progress to the extent that they become blind, particularly for type 1 diabetic. Kidney disease, 44% of patients who undergo dialysis have diabetes. And I'm going to concentrate on the nervous system disease or neuropathy in this case, because you have to deal with neuropathy more than any other complications, primarily because you can refer a nephrotic patient to a renal nephrologist, a chest pain patient to a cardiologist, but you can hardly refer any patients with peripheral neuropathy to a neurologist, because there is no neurologist that specializes in diabetic peripheral neuropathy. Again, as a reminder, these are the main complications of diabetes, and it is clearly established that most of the vascular complications of diabetes is correlated with the degree of glycemic control, whereas the macrovascular complications, there's really no clear-cut relationship to glycemic control. There are many other factors that are involved in leading to the macrovascular complications of diabetes. In terms of peripheral nervous system, the main fibers that are affected are the motor, sensory, and autonomic nervous system. With the motor involvement, which is rare, it involves less than 10% of diabetic patients. These are mainly the alpha fiber or myelinated fiber. With the thinly myelinated large fiber, the touch, vibration, position, perceptions are affected. In terms of the sensory, this is the most common one, common part of the nervous system that's involved, and this can affect as much as 60 to 70% of diabetic patients. So it's mainly the A-delta fibers that are affected, and you have problem with cold or warm perception, and you have pain. And less commonly, you have autonomic nervous system involvement. These are the thinly or unmyelinated C fiber part of the nerve. The reason you have to distinguish between these different types of the thickness of the fiber and the diameter of the fiber is because treatment will be different for predominant involvement of small autonomic or large fiber. The large fiber neuropathy are mainly motor neuropathy, and it's mainly a gluteal iliopsoas muscle involvement and limb girdle involvement. As a result, you can see that the patient has difficulty climbing stairs, and usually this is accompanied by severe cachexia. When you see an elderly subject with a very thin hip and has difficulty climbing stairs, and you look at their gluteal muscles and iliopsoas muscle and it's atrophic, most likely they have large fiber involvement. In terms of small fiber neuropathy, as I said, this is the most common cause of peripheral neuropathy in diabetes, affecting about 70% of the patients. And in addition to the stacking and glove distribution, usually it starts from the toes and then it goes to the foot. Once it reaches about the knee level, the hands will be involved. In terms of proximal motor neuropathy, as I mentioned before, it's a part of large muscle neuropathy. And you also get all those acute mononeuropathies. And you have all sorts of collagen disorders, such that carpal tunnel syndrome, tarsal tunnel syndrome are much more common in diabetic compared to non-diabetic patients. And of course, you have pressure pulses in diabetic patients. So which are the more common neurologic presentation of diabetes? The most common mononeuropathic involvement is the third cranial nerve involvement. When the patient comes to you with ptosis, unilateral ptosis, what is most important for you to determine is whether their pupils are involved or not. Primarily because if there's a pressure on the third cranial nerve, the pupillary reaction of the third cranial nerve is on the periphery of the nerve, and the central portion is in the motor component of the nerve. Therefore, if you have compressive symptoms involving the third cranial nerve, your pupillary reaction will be affected. Whereas if you have typical ischemia of the third cranial nerve, which occurs in diabetic, the central portion of the third cranial nerve will be involved. Therefore, the pupils will not be dilated. This is actually a quite common complications of diabetes. I have seen a lot of these types of patients. They come to you with ptosis and said, what should I do? So all you need to do is to look at their pupils. If their pupils are dilated, you need to be aware that it could be a serious problem, including the presence of supratentorial mass, aneurysm, particularly the posterior communicating artery. I have 2 cases within this month of aneurysm involving posterior communicating artery. It could be subarachnoid hemorrhage, sarcoidosis, lymphoma, and metastatic cancer. So, however, if the patient comes to you with ptosis, but their pupils are reactive, you can assure the patient that most likely this is a ischemic problem from diabetes, and it will reverse itself in 3 to 6 months. Again, if there's pupillary involvement, you need extensive neurological evaluation, including MRA or angiography. The second most common cranial nerve involvement will be the fourth cranial nerve. When the patients start complaining of experiencing diplopia when they look through the lateral gaze, then you have to pay attention. Most likely, it's also a ischemic disorder. And the third most common is cranial nerve 6, which is Actually, other neurological problem will be more commonly involved the cranial nerve 6. Now, there are other causes of small fiber neuropathy in addition to diabetes. Don't assume that because the patient is diabetic, it's all about peripheral neuropathy from diabetes. So, if a diabetic patient presents with painful neuropathy, you still need to go through the differential diagnosis of neuropathy, including connective tissue disease, sarcoidosis, hypothyroidism, vitamin B12 deficiency, HIV infection, hepatitis C, celiac disease, neurotoxic drug exposure, and paraneoplastic syndrome, and some of the weird hereditary causes which will usually occur earlier in life. Therefore, a basic workup for peripheral neuropathy, in addition to checking their glucose. For pre-diabetic subjects, you may have to do oral glucose tolerance test. You have to do lipid panel, SED rate, TSH, ANA, extractable nuclear antigen, ACE level, serum and urine immunofixation test, vitamin B12 level. These are the minimum workup for peripheral neuropathy. So how do you evaluate a patient with small fiber neuropathy? The only gold standard way is skin biopsy. The neurologists do punch biopsy of the distal legs, distal thigh, and proximal thigh, especially if you're not sure whether this is a chronic demyelinating immunopolyneuropathy. CDIP is 11 times more common in diabetic subjects. And since they are it's a type of peripheral neuropathy that's responsive to intravenous gamma globulin treatment, therefore it's important to keep that differential diagnosis in mind. Otherwise, you'll be trying different types of pain pills and not getting to the correct treatment because you did not do the EMG nerve conduction test and the CSF protein studies that's needed for CDIP. Okay, and some people use QSART, which is a quantitative pseudomotor axon reflex testing, which is not commonly used in diagnosing peripheral neuropathy from diabetes. Nerve conduction velocity is usually not very useful except for proximal motor involvement, so is EMG. However, nerve conduction velocity is good for monitoring the progress of the course of neuropathy, whether it's getting worse quickly or not in subjects in which the initial test was abnormal. In terms of the treatment, the antidepressants, anticonvulsants, topical anesthetics, and opioids are the standard treatment for diabetic neuropathy. So how do you decide on which one should you choose for treatment? If it's a burning, lancinating pain, most likely it's the unmyelinated C fiber that are involved, and clonidine and capsaicin cream, clonidine as a pill or patch would be effective. If it's a deep-seated, dull, aching pain, most likely the delta fibers are involved. So you use either a cough medication, dextromethorphan, or antidepressants and tricyclic agents like amitriptyline, nortriptyline, etc. And occasionally, if it's very disturbing to the patient, insulin infusion can alleviate the pain also. If they have increased sensitivity to blanket, etc., the best treatment would be dextromethorphan because it acts as an N-methyl D-aspartate receptor antagonist. The most common type of presentation is shooting or electric shock-like pain. Then you can use carbamazepine. This is actually quite effective in this type of patient. Gabapentin, pregabalin, or Topamax. If it's a large fiber neuropathy, mainly proximal muscles involvement, exercise, balancing exercise, including Pilates, yoga, and Tai Chi should be advised. In the American Diabetes Association has published yearly what we should do with each type of complications, and there's increasing evidence that infusion with alpha-lipoic acid, which has been confirmed by several randomized trials, which we don't use as a standard treatment right now, there's enough evidence that alpha-lipoic acid, if given by intravenous route, has a significant effect in controlling neuropathic pain. And the first line of therapy should be tricyclic antidepressants, anticonvulsants, and serotonin and norepinephrine reuptake inhibitor, particularly duloxetine or Cymbalta. And if this cannot be controlled, you can use oxycodone and tramadol or 5% lidocaine at the area where it's most painful. You apply that patch for 12 hours and then remove it for 12 hours. In terms of prognosis, about 12% of patients showed large fiber involvement. Most of them are small fiber involvement. Neuropathic pain gets worse in about 30% of the subjects, and it can resolve spontaneously in 11% of the diabetic patients. Okay. The next part is on the skin complications of diabetes. You must remember that diabetes affects all the collagen formation of the body. Therefore, it affects any part of the body that has collagens. There is erythema of the proximal nail fold with some prominent superficial vein. These are periungual telangiectasia. This is very common in diabetic patients. Necrobiosis lipoidica is also common, and you see all this pigmented purpura, especially in pretibial area. Less common is bullosus diabeticorum. These are bullae in the shin area, which are usually sterile. Only 0.5% of diabetic patients will come with that. And all you have to tell them is we don't know the etiology, we don't know the treatment, just it's usually sterile. Therefore, occasionally, I just saw one patient this week who presented with this bullae in the sole of his feet, and he wants to know what they are. And so it's an uncommon complications of diabetes. Necrobiosis lipoidica affect about 1.6% of diabetic patients. It's a non-scaling plaques with yellow atrophic center, primarily because the dermis are getting very thin, so you are actually seeing the subcutaneous fat. And they have surface telangiectasia if you look at it closely, and they have biolaceous border. The problem with this lesion is ulceration. It can occur in 35% of cases. And the treatment usually is topical steroid or intralesional steroid. Occasionally, you would need chloroquine or cyclosporine. It's not quite common. I have exactly 2 patients right now with this type of lesions in unusual location. One person has it in the armpit, you know. So this is not a very common lesion of diabetic. You can get lichen rubor planus. These are hexagonal shaped lesion with red border and usually it's erythematous lesion. And diabetic dermopathy. This you need to be aware of because this is a pigmented pretibial papules. It affects about 7 to 70% of diabetics and 20% of non-diabetic. The reason you need to be aware of this lesion is because this is associated with microvascular complications. If you treat them with aspirin, it will go away. Candida infection can involve every part of the body, including the mouth, around the nails, between fingers and toes, under the breast, in the corners of the mouth, which is common in children, under the foreskin, in the armpits and groin, and vaginal candidiasis is a very common presentation for new onset diabetes. Yellow nails. 40 to 50% of diabetic patients had yellow nails. It does not mean that they have onychomycosis because usually it's an end product of glycosylation. And there's a diabetic thick spleen or scleroderma, primarily involving the dorsums of the hands in 20 to 30% of diabetic patients. And there's such thing as diabetic hand syndrome, in which they have stiffness of the metacarpophalangeal and proximal interphalangeal joints because of the collagen involvement. So don't diagnose them, all of them, with osteoarthritis. Dupuytren contracture, if you don't know whether the patient has long time duration of diabetes, all you have to do is to ask them to show your palm, and then you feel for their tendon there. If it's hard and stiff, most likely they have Dupuytren contracture and at least 20 years of diabetes. And as I said, scleroderma diabeticorum, these are thickening of the skin in the posterior neck and in the back, especially in the scapular and interscapular area. Acanthosis nigricans is a manifestation of insulin resistance. It's a reversible lesion. It can be painful, malodorous, or macerated, especially in children. It can be treated with salicylic or retinoic acid, or occasionally, if the manifestation is severe, you may have to use Accutane in these subjects. Skin tags is very common in diabetic. If you find skin tag in the subjects, there's 25% chance that they have type 2 diabetes and 8% chance that they have pre-diabetes. In terms of autonomic neuropathy, I'm just giving you a rundown of the complications that we usually do not think about, okay? If a patient has resting tachycardia, exercise intolerance, those long-term diabetic patients who came to you huffing and puffing because they're very short of breath, that's exercise intolerance, which you probably see in a lot of your type 2 diabetic patients. The problem you need to be aware of this is they have problem with intraoperative and perioperative cardiovascular instability. These are the subjects who will have problem with extubation after general anesthesia. They're the one who will be hypotensive after general anesthesia. And they will be at risk for silent MI because they have cardiac denervation problems. So you just need to be aware that if a patient that's resting and their heart rate is over 100, you need to warn the anesthesiologist that most likely this patient has autonomic neuropathy, and there's usually a problem with extubation after general anesthesia. In terms of erectile dysfunction, this usually affects 1/3 of men, 12% of men younger than 59 years old, 22% of men that are between 60 to 69-year-old have erectile dysfunction, and about 30% of men over 69 have erectile dysfunction. However, it's much more common in diabetic patients. Over 50% of diabetic patients have erectile dysfunction. The cause is usually multifactorial. It's rarely ever hormonal in etiology. Low testosterone accounts only for about 5 to 10% of the cause of erectile dysfunction in diabetic. Most of the time, it's a combination of vascular, neurogenic, anatomic, drug-induced, or psychological problem. The pathophysiology mainly is, in addition to elevated advanced glycosylation end product and increased oxygen-free radical, there is impaired nitric oxide synthesis. This is very important. The reason is you need vasodilatation for the arterial engorgement of the cavernosum. And you also need a decrease in cyclic GMP-dependent protein kinase, which is where the phosphodiesterase inhibitors act. You need to be aware that a lot of the medications, it's not only beta blocker that cause erectile dysfunction. The opiates, tricyclic antidepressants, dilantin, phenobarbital, lithium, antihistamines, clonidine, spironolactone are very common thiazides. Hydrochlorothiazides is a very, very common cause of erectile dysfunction. Lopid, Norpace, and some of the hormone inhibitors, and interferon alpha. So many times you have to change their antihypertensive and antidepressants in order to resolve their erectile dysfunction. So the initial evaluation includes cardiac, thyroid, testicular, and prostate exam in addition to the blood pressure. You need to look at their penile anatomical abnormalities. I just had a patient this week who came with erectile dysfunction, and his problem is really a bent penis or Peyronie's syndrome, or gynecomastia from spironolactone and other medications. Okay. In terms of treatment, the phosphodiesterase type 5 inhibitors are the most effective oral treatment. It's the first-line treatment, but 1/3 of men with erectile dysfunction do not respond to PDE5 inhibitors. The adverse effects are, of course, headache, flushing, dyspepsia, rhinitis, abnormal vision. The reason for abnormal vision is in addition to phosphodiesterase inhibitor 5, this enzyme is present in the penile vasculature. It's also present in the retinal layer of the eye, but specifically it's type 5 enzymes that's present, type 6 enzyme that's present in the retina. So there's an overlap between the type 5 inhibitors and type 6 inhibitors. That's why you have the visual problem. Rare problem includes dizziness, syncope, non-arteritic anterior optic neuropathy that can lead to blindness. So the way it acts is with inhibition of this enzyme, phosphodiesterase inhibitor type 5, there will be increased cyclic GMP in the corpus cavernosum, opening the potassium channel, leading to hyperpolarization of the muscle membrane, inhibition of calcium channel, leading to decreased cytosolic calcium and relaxation of the smooth muscles. So you have relaxation of the smooth muscles of the penile artery, followed by occlusion of the venous system, leading to engorgement. So, what are the drugs that interacts with PDE5 inhibitors? Include nitrates. If your patient is using nitrates, it's an absolute contraindication to use the PDE5 inhibitors. If they're using alpha blockers, it's contraindicated with tadalafil and Cialis and, not Viagra. Cialis and Levitra are contraindicated if they're using alpha blocker. Drugs that prolong the QT interval, a lot of antiarrhythmic agents should be prohibited if they are using vardenafil. Okay. Drugs that increase levels of PDE5 inhibitors are mainly patients with HIV patients. You need to be aware that these are contraindicated. And of course, anti-seizure medications, a lot of them are cleared through cytochrome P450. In terms of Viagra, the initiating dose is 50 milligram, titrated up to 100 milligram PRN. The mean half-life is 4 hours. Duration of action is 4 hours. It's 10-fold more potent for PDE5 inhibitors than for PDE6 present in the retina. It can be used with alpha blocker, and there's no, you have to decrease the dose based on the renal function. And high-fat meals will affect the concentration of Viagra. It does not have potentiation of the hypotensive effect of alcohol. Alcohol causes vasodilatation, so it is advisable that they do not take these PDE5 inhibitors with alcohol, particularly for Levitra and Cialis. Again, as Levitra is 10 milligram once daily. Again, the half-life is about the same as Viagra, and duration of action is also the same as Viagra. It's more selective for PDE5 than PDE6, so less eye problem. The biggest eye problem, the blue coloration of vision and then the blindness, usually is the highest risk is with Viagra. However, you cannot use it with alpha blocker and other antiarrhythmic medications. Cialis can last up, half-life is 17.5 hours. Duration of action is up to 1.5 days. It's the most selective for PDE5 than compared to PDE6. And again, it's contraindicated with alpha blocker and antiarrhythmic agents. And it's not affected by alcohol. It is affected by alcohol consumption. So only Viagra is not affected by alcohol consumption, whereas Cialis and Levitra are affected when you have concurrent alcohol consumption. Now, A lot of obese subjects have total testosterone less than 300 nanogram per deciliter. So, if there's a diurnal pattern to testosterone secretion, therefore, if their morning testosterone is less than 300 nanogram per deciliter, it may be helpful to give them testosterone at the same time as PDE5 inhibitors. Of course, you need to be, in general, the response rate is higher if you have primary testicular problem than if you have secondary testicular problem from hypothalamic pituitary dysfunction. The transdermal preparation is better than oral or IM preparation. It can be added to sildenafil or Viagra. The adverse effects that you need to monitor include erythrocytosis, elevated liver function tests, exacerbation of untreated sleep apnea, benign prostatic hypertrophy, and adenocarcinoma of the prostate. So you need to check their PSA and do rectal digital examination of the prostate gland. There are other surgical options, intracavernous injection of Caberject or alprostadil. It's an alpha adrenergic agent. Is given by urologists. The problem is penile pain, urethral bleeding, hematoma, nodule formation. You can form plaques and priapism. If you encounter a patient with priapism, the treatment are mainly aspiration of blood from corpus cavernosum under local anesthesia or intracavernous injection of phenylephrine and with cardiac monitoring at the same time. We also prescribe vacuum pump devices for patients with erectile dysfunction, but this is contraindicated in patients with sickle cell disease and blood dyscrasia. And if this does not work, then surgical implantation of penile prosthesis will be indicated. And these are the vacuum device that patients could use. They put a ring on the base of the penis and then use the vacuum to cause engorgement. And these are the penile prostheses that are used. They still have to pump it like a blood pressure cuff to induce engorgement. Okay. The next part of our discussion is the foot problem of diabetic. The reason is this is the most neglected examination, leading to a lot of subsequent complications. When you do a foot exam, you will feel for the dorsalis pedis and the posterior tibial pulses. If the pulses is good, that does not mean you're home free. Because if the pulses is actually very good, like bounding pulse, you actually have a problem. In terms of neuropathic evaluation, using the Siemens-Weinstein monofilament, you test this specific area. These are the standard area that you check. When you do the monofilament test, you make sure that you apply enough pressure so that the monofilament should bend. If you don't apply enough pressure, that's not a valid test. Foot ulcers occur in 15%. You also need to look at the range of motion and look for deformities. Foot ulcers occur in 15% of diabetic population. 50% of whenever patient had a foot ulcers, there's a 50% chance of recurrence within 2 years. And 20% of patients with foot ulcer will undergo amputations. 50% of amputations can be prevented. 8% of diabetic admissions to the hospital are related to foot problem, and the direct cost is actually quite high, 1.8 billion a year in terms of direct medical costs. What are the more common manifestation of diabetic foot? First, you have wasting of lumbrical and interosseous muscles of the foot. So you have atrophy of the muscles in between the foot. As a result of the atrophy of the muscles, you will end up with a collapsed arch, so that the first thing that you observe is a flat-footed person. And as a consequence of this muscle atrophy, eventually there is an imbalance of the flexion and extensor muscle strength, and you'll end up with a digital contracture. This week I just had a patient who came to me and said, "What's happening to my fifth toe? It's now deviating inward. There's something wrong," okay? So usually that's a manifestation of neuropathy and imbalance of the extensor and flexors of the muscles. Eventually, because of that imbalance of the flexor and extensor, you'll end up with a cocked-up toes or hammer toes. Eventually, you'll end up with equinus deformity of the ankle. So the back of the foot is like that of a horse, and varus hind foot. Okay. So, a typical neuropathic ulcer will be in unusual location like this area. Whereas a typical vascular ulcer will be in the metatarsal head of the first and the metatarsal head of the fifth toe. So, if the patient presented with ulcers of the foot, you look at the location. If it's in the metatarsal head of the first and the fifth toe, you need vascular evaluation. If it's somewhere else in the digits, like here or in between the toe, most likely these are neuropathic ulcers. Again, this is a typical vascular ulcer. Okay, so ischemic ulcer is just in these two locations most of the time. So you need to be aware that you do not just treat the ulcers, but you also need to treat the vascular problem of the patients. Okay, so there's such thing as acute Charcot's foot in diabetes. This is one of the complications of diabetes that's mostly missed by all of us, okay? When the patient comes to you with pain in their legs and there's swelling of one leg but not the other, think of acute Charcot's foot. So what's an acute Charcot's foot? In the posterior column of your spinal cord, the anterior horn of the cells maintain the sympathetic innervation to the bones and the legs. If there is significant neuropathy, it's like having a sympathectomy. So you'll end up with dilatation of the vessels to the bone of the legs. As a consequence of the flooding of the bone to the legs, there will be severe pain. And these are non-pitting edema. These are non-pitting edema. So when you have a patient with a unilaterally swollen legs, just don't think that, oh, I have to rule out DVT. When you feel for the dorsalis pedis pulse, because it's a flooding situation, there's a lot of blood flow to the legs, you'll feel a bounding pulse. So the pulse is very good, more than normal. And there's a increased warmth to the legs, and it's a non-pitting edema. The reason you need to be aware of these complications, and this is the part where you can save the legs, okay? They have to be on total contact cast or pressure relief ankle foot orthosis for at least 6 to 8 weeks. So you advise the patients to have bed rest at that point, ask the podiatrist to put these orthotics on their foot, okay? This is an example of a acute Charcot's foot. You see that this commonly in the clinic. What happened here is there's flooding of the bone, so there's a lot of bone fusion. So instead of this 5 calcaneal bone, you'll have a lot of bone fusion, bony fragmentation, swelling and redness of the foot, shortening of the first metatarsal bone. Okay, so there's a fusion of all this bone. If you do an MRI, this is what you see. So you don't see the bony cortex. It's essentially a swollen bone. If you put them in the proper orthotics, and sometimes we do bisphosphonate infusion to decrease the osteoclastic activity, which will decrease the duration of pain. And if you put them on the proper orthotics and put them on bed rest, eventually the bone will reform. The fusion will go away, and you essentially save this foot. So it's important to be aware of this acute Charcot's foot. The incidence is as high as 1% to 13% in some reported cases. This is where this is the part of the foot problem that is reversible. The standard for diagnosing it right now is MRI of the foot. In terms of peripheral vascular disease, when the patient complains of pain in the distal foot when they're supine or resting, does not always mean that it's neuropathy. In fact, you need to think of peripheral arterial disease. Pallor on elevation, and they want to keep on sitting up or stand up primarily because it's a dependent pressure, how do you call it? It's if they lower their legs, okay, the pain will go away. So that's a sign of peripheral vascular disease. It's more common in African American, threefold increase in diabetic patients. Now, we keep on thinking of intermittent claudication. Intermittent claudications occurs only in 10% of patients with peripheral vascular disease. It does not occur at rest. Usually when patients walk, they'll have the pain in their calf area, and it usually disappears within 10 minutes of stopping to rest. However, majority of the peripheral vascular disease do not present as intermittent claudication. Rather, they present as fatigue, numbness, tightness, heaviness. They walk slowly. They cannot walk too far. So these are very non-specific complaints that they complain about. It's the same way that patients will always come to you and said, I have my problem with my knees. It seems like it's giving out all the time. It does not mean that they have severe osteoarthritis. Many times it's because of their gluteal muscles weakness, and it's a neuropathic symptoms. It's the same with the peripheral vascular disease. They usually do not come with you complaining of claudication pain, but this tightness, heaviness is quite common. And 40% of patients with significant peripheral arterial disease do not even complain of any leg pain. Be aware that if they have aortoiliac disease, they can present as buttocks, hip, or proximal thigh pain. If they have femoral arterial disease, they can present as thigh and calf pain. If it's a popliteal or superficial femoral arteries disease, you have calf, ankle, and foot pain. The standard way to make the diagnosis is to do ankle brachial index. You send them to the 5th floor or 7th floor of HOC, where they can measure the ankle brachial index. Is essentially a blood pressure measurement of the ankle versus your brachial, the ankle pressure should be at least 90% of your brachial pressure. If it's lower than that, then you need to suspect peripheral arterial disease. Be aware that most of the vessels, they could have normal ankle brachial index in diabetic patients, primarily because the main pathology is calcification of the vessels, which will give falsely elevated pressure in the ankle area. If they do Doppler, which they do as a standard when you ask for ankle brachial index measurement, they'll show you this nice waveform for normal artery, whereas with peripheral vascular disease, it's actually this very distinctly different form. Again, at least normal ankle brachial index is 0.9 to 1.3. Mild disease is 0.7 to 0.9. Again, it's relative ankle systolic versus brachial systolic pressure. If it's less than 0.4, it's severe disease. Just because they're diabetic does not mean it's all about neuropathy. If they complain of painful thin foot, you need to think of claudication, Charcot's neuroarthropathy, plantar fasciitis, osteoarthritis, radiculopathy, look for Morton's neuroma, and tarsal tunnel syndrome. In terms of treatment for peripheral arterial disease is aspirin and Pletal, 100 milligram BID. If you encounter minor foot ulcerations, the patients will come to you with that problem. Just ask them to clean the wound with soap and water or normal saline twice a day. Apply antibiotic, including basotracin, polysporin, neosporin. And if they have quite a big lesion, make sure that you apply hydrogel so that it does not stick to the dressing. And use sterile gauze and paper tape. Do not ask them to use other types of tape. Change dressing at least twice a day. The standard treatment for diabetic foot ulcers include anaerobic coverage, Civox, pen plus sulfabactrim. I'm sure you'll get this in your ID class. In terms of, since Dr. Krishnasamy is here to give the next lecture, I'll just go through this quickly. In terms of hypertension as a complications of diabetes, blood pressure should be maintained below 130 systolic over 80 diastolic. But if they have proteinuria, the standard change. Their systolic should be less than 125 and diastolic should be less than 75. ACE inhibitors or ARBs is used as a primary treatment. ARBs if you have problem with coughing and hyperkalemia. ARB is less hyperkalemic compared to ACE inhibitor. Diuretics will be the second choice for hypertensive control. If your creatinine is more, serum creatinine is more than 2, you should not be using hydrochlorothiazide, but you should be using furosemide. The third will be beta blockers, calcium channel blocker, and other agents. In terms of retinopathy, I'm just running through this quickly right now. For a type 1 diabetic patients, they have to be screened for retinopathy within 3 to 5 years of diagnosis after age 10. If they're prepubertal, even though they have diabetes from age 1, chances are they will not develop any retinopathy. Something about the growth factors, growth hormone that increase during puberty will induce and contribute to retinopathy. For type 2 diabetic patients, they need a screen at the time of diagnosis because primarily it could be silent for a long time. Pregnancy, you need a screen on first, second, and third trimester because the increased growth factors during pregnancy can accelerate retinopathy. Indications for cardiac testing in patients with diabetes. These are the recommendation of American Diabetes Association. If they have typical or atypical cardiac symptoms, resting EKG suggestive of ischemia, peripheral or carotid artery disease, if they have sedentary lifestyle, age over 35, which is practically everybody, or if they had 2 or more risk factors in addition to diabetes. In terms of lipid control, without overt cardiovascular disease, their LDL should be less than 100, and anybody with diabetes, upon attainment of age 40, they need to be put on statin therapy regardless of their baseline LDL. Individuals with overt cardiovascular disease, their LDL should be less than 70. Additional goals include triglycerides of less than 150, HDL of more than 40 in men, and more than 50 in women. I think I'll end. It is clear in most of the longitudinal long-term study that glucose control is very important for preventing and delaying the microvascular complications of diabetes for type 1 and type 2 diabetes. However, it's the relation to macrovascular complication is less clear. So I guess Dr. Krishnasamy is ready to give the next lecture. Any question about diabetic complications? Everything is clear. Okay, thank you for your attention.